Thank you, Dr. Mohammed, for the kind introduction, and thank you, SSBMT, for the invitation to talk to you today. And my talk will be on the management of follicular lymphoma beyond the first line. So to start with the incidence of follicular lymphoma, we know that it differs between different ethnic groups, and this study was done in England. And if we say Caucasians are one, you see here that South Asians and Bangladeshi Indians, their incidence is less than the Caucasians. Also, Black Africans and Chinese have a lower incidence than the Caucasians. So there is some biology there, maybe related to ethnicity or social, environmental factors. So our management for follicular lymphoma has been improving over the years, and you can see this is a Spanish study showing that over the many years, the improvement in survival of the follicular lymphoma patients and progression-free survival. However, the incidence of transformation has not changed despite the change in our therapies, as you can see here. So patients who are diagnosed with follicular lymphoma, they still don't do as well as the general population. So this dotted line is the general population in Spain, and you can see the follicular lymphoma patients, they are not doing as well as the general population. So there is a reduction in their overall survival. However, over the decades, there has been an improvement, and you can see the curves of follicular lymphoma patients coming closer to the general population with the advancements of our therapies. This is Stanford data, very similar to the Spanish data, showing the improvement along the years. And the usual median survival for a follicular lymphoma patient now is about 20 years. This is again the Stanford data, and you can see that as time passes by with the newer therapies, the survival of follicular lymphoma patients is coming closer to the general population also. So the first question is, does patients need treatment? Do relapsed follicular patients need treatment? And to answer that question, most of us use one of these criteria to treat a relapsed patient, like the British criteria for life-threatening organ involvement, B symptoms, bone marrow failure, rapidly progressing disease over a period of 3 to 6 months. The French have their own criteria, the GELF, which is used widely over the world, bulky disease, B symptoms, beta-2 microglobulin, involvement of 3 lymph nodes, and splenic enlargement and compression syndromes, and pleural peritoneal effusion. But we have to realize that all these criteria were made for clinical trials, to enroll patients into clinical trials. But in clinical practice, maybe we have to think carefully before we start treating follicular lymphoma patients. There is this study in which asymptomatic follicular lymphoma patients were given rituximab. When you compare those who did not, those who were on watch and wait, their progression-free survival is less than those who had rituximab. Also, their time to start of new treatment is less, or quicker than those who had rituximab. However, when you come to the overall survival, there is no difference between the two groups, those who were treated with rituximab and those who were not treated. So treating patients who do not need treatment is not necessary for relapsed follicular lymphoma patients. Who should we treat? Generally, in clinical practice, we should look at local symptoms due to progressive or bulky disease to treat a patient. If there is a compromise in the normal function of an organ, if there are B symptoms, and if there is extranodal disease outside the bone marrow, like in the lung or the liver, then we should think of treating these patients. And if there is bone marrow cytopenias, and if there is a rapid progression of the disease that you see clinically. So in the future, this study was trying to see if PET scan could give us a clue on whether we should treat patients, and they defined what is low volume disease by PET scan versus high volume disease, and they've shown that high volume disease patients are patients who are going to require therapy soon. So maybe starting therapy in patients of follicular lymphoma in the future might depend on our PET scan and calculating the tumor metabolic volume. So who has worse progression when they relapse? The POD24 patients are known to get worse when they relapse. There are data that show that those patients who have POD24, they have high incidence of transformation. One study has shown 37% of patients with POD24 have transformation of their disease. Another study, 76% of patients have transformation of their disease. And because the treatment is very different, it's very important to identify which follicular lymphoma patients actually have progressed and transformed to diffuse large B-cell lymphoma. This is the first study to show the difference in survival and progression-free survival of those with POD24. This is another study of meta-analysis of more than 5,000 patients in 13 clinical trials, again showing that those who progress within 24 months of the end of their therapy, they do worse. Regardless of the therapy, even if they had R chemo, or if they had rituximab only, or if they had chemo alone, they do worse, as you can see in the curves here. So what type of induction chemotherapy that might influence survival? In the gallium study, they have did an analysis, and they have it was just an exploratory analysis, and that has shown maybe patients who have obinutuzumab, there is less incidence of transformation and or progression in POD24 than those who did not have obinutuzumab. However, those who have progressed, they have a very higher incidence of mortality, 26-fold more than those who have not progressed. So obinutuzumab therapy or obinutuzumab-related therapy reduces by 34% the incidence of POD24 in follicular lymphoma patients. However, post-progression, the worst prognosis still persists in these patients. There is another analysis of using bendamustine, and this has shown that the incidence of POD24, instead of being 20%, was 9 to 12%. So maybe there is a hint those who receive bendamustine have lesser incidence of POD24 progression or early progression. So transformation risk is about, in general, in follicular lymphoma patients, about 10% in 5 years. It's about 2% per year. And what type of transformation? Patients who transform at presentation are these patients, and they do as well as those who have not transformed. So transformed patients who present you with transformation, they don't do badly. However, patients who transform after having chemotherapy, these are the patients who actually do badly. It's important to know also that there are patients who we have confirmed evidence that they have transformed by biopsy, and there are patients who we suspect that they might have transformed, but when we do biopsy, their biopsy still shows that they have follicular lymphoma, but you clinically think they have transformed. And these patients, they do exactly the same. So the patients you suspect they've transformed, they do as badly as those patients who you prove they have transformed, as you can see here in these two graphs. So who are these patients whom we suspect they have transformed? They are patients who have rapid progression of lymphadenopathy. They are patients with extranodal disease outside the bone marrow. They are patients who develop B symptoms, and they are patients who have very high, rapidly rising LDH and hypercalcemia. And it is mandatory in these patients to do a lymph node biopsy because your therapy is going to change if you prove they're transformed or if you suspect they're transformed. This is another study by the Mayo Clinic, again showing that those who've transformed more than 18 months since end of therapy, they do worse than those who transformed before 18 months of end of therapy. Those who have transformation at diagnosis and they receive R-CHOP, they do as well as any diffuse large B-cell lymphoma patient. However, if patient transform after having R-CHOP chemotherapy, they do badly, as you can see here. And you can see in this graph here that patients who transformed at presentation, they do as well as a diffuse large B-cell lymphoma presenting to you in the clinic. The number of relapses will lead to worsening progression-free survival. As you can see here in this US data, the more therapies the patient receives, the less the survival is. So the summary of the slides, POD24 occurs in about 20% of patients. Unconfirmed reports that obinutuzumab reduces the incidence of POD24, and 50% of POD24 patients have transformed diffuse large B-cell lymphoma. And POD24 patients are unmet need. They do badly regardless of the therapies we have currently. Transformation to follicular lymphoma occurs in about 10% in 5 years, and transformed disease diagnosis is not a poor risk sign. But however, transformation after R-CHOP chemotherapy is a bad sign. So newer strategies for treating a relapsed disease, we have lenalidomide-based therapy, we have CAR T-cell therapy and bispecific antibodies and BTK inhibitors and EZH2 inhibitors. So the first trial is using rituximab lenalidomide in patients who had 1 line or more. They relapsed after 1 line or more. So rituximab versus rituximab only. And this study has shown that many of these patients actually had 3 lines or more, 25% of the patients. Those who are less than 2 years, so the POD24 in this study were half the patients. So these are the patients who actually do badly, as we have discussed. And you have seen here the lenalidomide rituximab has done better in terms of progression-free survival compared to rituximab, with an incidence of progression-free survival about 28 months. And there is a hint that there might be an overall survival benefit in this follow-up study. All groups do better with lenalidomide rituximab. And as you can see here, the marginal zone lymphoma patients who were there in this study actually might not have benefited, although the numbers are small. So this AUGMENT study, CR rates are 34 compared to 18. The secondary malignancies, which we fear with lenalidomide, were not increased. And the venous thrombosis, again, which we fear with lenalidomide, was not increased in this study. As you can see, the side effect profile, when you compare the two strategies, are very similar. So in conclusion, it improves CR rates and progression-free survival. However, there are more patients who had progression using rituximab only. More patients with R2 discontinued because of side effects, so 8% versus 4%. So maybe there is a hint of toxicity there. CAR T-cell, we have 3 products in the market, the axi-cell, the T-cell, and the lyso-cell. The difference between them lies in the hinge area. So you can see the hinge area of the antibody is different between the different antibodies. The transmembrane region, again, there is difference between the 3 different antibodies. And the most important is the co-stimulatory domain is different. And the CD28, which is in the axi-cell, leads the CAR T-cell to have a rapid expansion but shorter durability, while the lyso-cell and T-cell, they have the 4-1BB co-stimulatory module, which make it slower expansion but longer durability in the human body. So which strategy will win? We don't know yet. We don't have long-term follow-up. There is an update. axi-cell has the longest follow-up. And you can see in this study the progression-free survival of those patients with follicular lymphoma at 3 years is about 54%. So the overall survival at 36 months, which is 3 years follow-up, was about 76%. The progression due to death or competing reasons were acceptable between the groups. There is a message here, very important message about the bendamustine, which we might make us think what is our strategy should be in our follicular lymphoma patients. So those patients who had bendamustine within the last 6 months from the CAR T-cell, you can see their curve, they did really badly. Those who had 6 months to 12 months, their progression-free survival was slightly better. Those who had ever had bendamustine, again, they didn't do as well as those who never had bendamustine. So you can see the difference in the curves depending on which time, when they had bendamustine. So this is something we should think about. So the grade 3 toxicity from CRS was about 6%. Use of tocilizumab and corticosteroids, because this CAR T cell leads to rapid expansion. The toxicity from CRS and ICANS is higher than the others. Progression-free survival, this is a study using PET scan. And this study was in the 3 centers, and they defined that those patients who have a tumor volume of 510 centimeter cube usually do worse than those patients who have less. So these patients here are patients who have 510 centimeters or more. Their progression-free survival is worse than those who have less disease. So how do we benefit from this? In this study in the CAR T cell, they divided, they had a median volume for the tumor, and those who have lower tumor medium, they did better. As you can see here, these are the Q2 and Q1 are patients who have smaller, less tumor volume. They do better than those who have higher tumor volume. And the progression-free survival of those with lower tumor volume was 71% versus 37% for those with higher tumor volume. So tumor volume tend to have an effect. We talked about the CRS, the ICANS. 15% had grade 3, so higher incidence of ICANS in this CAR T cell. The liso-cel, we will concentrate on this group because this was published recently. This is the high-risk follicular lymphoma patients, the POD24 that we talked about. We don't know what to do for these patients, and they have looked at this group of patients in this trial, 2 lines, and then they progressed, and they are considered high risk, and they had the liso-cel CAR T cell. So how about the patient characteristics? You can see here the POD24, 65% of the patients had a POD24, so high-risk group of patients. And you can see here the CR rates of this group of patients is equivalent to the other group of patients who were considered as low risk. So treating them with CAR T cell made their prognosis similar to the other follicular lymphoma patient in terms of CR rates. How about their progression-free survival? Their progression-free survival is similar to what you see in the other groups. As you can see here, the orange curve is similar to the other curves. Overall survival, again, is similar. The progression-free survival at 1 year is 91%, so the follow-up is still very short to make major conclusions from this study, but it's very interesting. CRS rates, as you can see here, 0 grade 3 and 1% grade 3 in the 3 lines or more. Infections, again, not major infections, and toxicity and death was minimal. T-cell, no update, but these are their curves. As you can see, some response. So to summarize the 3 CAR T cells, the CR rates between the 3, we have higher CR rates with axi-cel and longer follow-up, 94% with liso-cel, but the follow-up is short. The progression-free survival is 54% in the axi-cel, 57% at 2 years for the T-cell, and 80% for 1 year in the liso-cel. The toxicity, higher toxicities with the axi-cel compared to the liso-cel and the T-cell. So the bispecific antibodies, mosunetuzumab is a CD20, CD3 bispecific antibody used for relapsed follicular lymphoma, 2 lines or more. So same area as CAR T cell therapy. And the characteristics of the group, there are 3% of the patients had CAR T cell. About 21% of the patients had autologous transplant in this study, so heavily treated patients, and any prior CD20 and alkylator double refractory patients were 50% of these patients, because one might think this works against CD20. If they are refractory to CD20 rituximab or obinutuzumab, this antibody might not work. However, half of the patients had refractory to CD20 therapy. Those who are POD24, half of the patients. So again, heavily pretreated patients, CR rate 60%. So a bit less than what you see in CAR T cell, but it's reasonable, decent. In the double refractory, it's about 50% of the patients achieve the CR rates. And in the POD24, again, 57%, so decent results. The 12 months progression event-free survival was 62%. The 18 months is 57%. Less than CAR T cell, median progression-free survival 17.9 months. These are the patients, the blue ones are patients who achieved CRs. And this is their curves, progression-free survival, which is 17.9 months. So this is an update of their results, extended follow-up, and it's still showing a duration of response quite reasonable, and especially in those who achieve a CR. So in conclusion, after a median study of 38.9 months, no relapses were observed in those who achieve a CR beyond 26 months. The duration of response in all patients was about 23.2 months, and the complete responders is not reached yet. So toxicity, we have grade 3, 1%, and grade 3 ICANS, 0%. And we move on to ipacrutimab, which has been approved by FDA for treatment of follicular lymphoma in August this year. And we concentrate on 128 patients. Looking at CR rates, the POD24 were about 50% of the patients, and the follow-up was about 17.4 months. Adverse reactions in 19 months, and they did not report the progression-free survival, but it looks like 15 months, the progression-free survival. Their overall response is 82%, CR rates is 62%. 3 out of 6 patients who had CAR T cells responded and achieved the CR. They had MRD negativity, did well. Cytokine release syndrome was high. 40% of patients had grade 1, and grade 2, 25% of patients, and 2% of patients had grade 3 cytokine release syndrome. ICANS, 6% of patients had ICANS. So zanubrutinib obinutuzumab versus obinutuzumab. This is an interesting Rosewood study. Again, the POD24 patients were 30% of the patients, and the overall response rates was 69%, CR rates was 57%, and the 18 months rate was 69%. Progression-free survival was 28 months, so reasonable progression-free survival in this difficult group of patients. And you can see here the duration of response and progression-free survival of 28 months. So all groups benefited from zanubrutinib obinutuzumab. Toxicity is mainly thrombocytopenia, infections, and secondary malignancy. So stem cell transplant in follicular lymphoma works. This is a study showing that autologous transplant works compared to no transplant. This is a registry data which has shown that autologous transplant compared to allogeneic transplant, we have non-relapse mortality is higher in the allogeneic group, relapse rates is higher in the autologous group, and then the progression-free survival is better with the allo. The overall survival is equal because they cancel out the non-relapse mortality with the relapse. So this is a strategy we can use, especially for those who had failed after CAR T cells using allogeneic transplant. So I'll try and finish quickly. Matched siblings, mortality 17%, match unrelated 33% mortality. Conventional versus reduced intensity is equivalent, so that's why we use reduced intensity transplants for follicular lymphoma. And we'll move to the conclusion. There are plethora of new treatments for relapsed follicular cell lymphoma patients being approved at the same time, which confuses physicians. And as physicians, we have to have optimal sequencing of therapy. And to do this, we have to know the benefits and risks of each treatment, and also to weigh the benefits and risks against patient factors, how frail the patient is, the disease-related factors, how aggressive the disease is, and choose the right treatment for our patients. Fit patients might benefit from CAR T-cell therapy, less fit from bispecifics, and frail patients from less toxic therapies like zanubrutinib or obinutuzumab. And thank you.